That was a terrific lecture, just magnificent images. I'd like to introduce the next keynote lecturer, Dr. Jens Overgaard. And although in a moment you'll get to hear his terrific style of presentation, I wanted to tell you a few things that you probably don't know about Dr. Overgaard. He's quite a talented dancer, I understand. Here he's with his wife, Marie, who is also an internationally acclaimed oncologist. He's known as a rugged outdoorsman, with one of his grandchildren here showing them the ropes of outdoor life. He's a NASCAR aficionado, here in one of his favorite powered vehicles. A known sportsman. Certainly a phenomenal instructor of new generations. And a global diplomat, as seen in this slide. Again, as you'll see in a moment, he's really a master of the podium with a terrific sense of humor and intellect in delivering material with tremendous intrigue. And it's a pleasure to introduce Jens, who is an international oncologist, talented teacher, leader, and thinker who has published over 550 papers, over 400 in the peer-reviewed literature, has made over 700 presentations over his career, but moreover has inspired many oncologists and junior faculty and residents and registrars and fellows to serve in oncology. And he has influenced oncologic practice not only in his home country of Denmark, but throughout Europe and throughout the world. And so with that, it's my pleasure to introduce Dr. Jens Overgaard.
Thank you, Paul. It's very nice words. I'd rather be in the hammock. I'm going to discuss the issue of radiation therapy for head and neck cancer. And you're supposed to disclaim and disclose something. So I will just tell you that this talk is not going to cover everything related to radiotherapy for head and neck cancer. There is so much and the time is so little. But I will constrain myself, at least partly, to issues of general pragmatic relevance and where there exists a strong evidence-based information. And I also will tell you that I'm not in the pocket of anyone. Well, head and neck cancer is a global disease. And you know it's about 7% of all cancers in the world, and 3/4 of these are in the developing countries. And I think we should remain that when we discuss how we can achieve improvement within the area. It is a disease of great heterogeneity. Even within the European countries is the variation quite large. You can see here both in terms of incidence and outcome. And not only is it a heterogeneous disease, but it is also treated very heterogeneously. So the treatment strategy is very diverse. And in fact, you can all kind of elements here in forms of surgery alone, or radiotherapy alone, and chemotherapy, and all the mixtures you can imagine of these issues. There is no consensus, and there is no strong evidence which favor one strategy against another. And in fact, head and neck cancer is one of the few cancers, except skin and things like that, where you actually can achieve the same outcome by different means. And this is just for the comparison between the Ontario and the SEER register, which illustrates a primarily radiotherapy-oriented approach versus a primarily surgical approach that you achieve almost the same outcome. And when we looked up how it was back home, it was in the same ballpark. So there are different ways to achieve the goals. So our situation is that we all want to go for the highest peak. And we are probably climbing the same mountains in order to achieve what we want to do. But can we reach the top by different routes? And can we do it with the same cost? And this is what we're going to address. Now, you may consult some experts about how you should do that. And you might be in some doubt who you should trust. Should you trust the surgeon, the medical oncologist, or the radiation oncologist? Now, sometimes you should not take things for face value, but you have to go behind the back, and you can see which one you will rely on. So I'm going to give you the point of view for the radiation oncologists. Now, why do we not cure all patients with head and neck cancer? Well, if you take a cohort of patients, this is from the Danish head and neck cancer database with more than 15,000 patients, you will see that if you have a local control of the patients, 92% of the patients, in fact, will not die from the cancer. Whereas if you fail for the local regional control, only 19% will have a 5-year survival. And that is obvious when we look at the patterns of failure of these patients here. Where does the patient fail? Well, 78% of patients fail in the T site alone or together with other sites. And about 1/3 will fail in the nodal site, and 16% have distant failures, but only 7% have distant failures alone. And in fact, this is about 2% of the total cohort. So there's no doubt that carcinoma of the head and neck is predominantly a local regional disease, and the distant metastases are mainly a consequence of local failure. So the treatment aim must be towards controlling the primary tumor and the regional lymph nodes. Now, you can do that easily with radical head and neck surgery. And here you have an example of such an approach. And you can see here, and you might, of course, wonder whether you have residual tumor. And you might even do some research and take the specimen away and do some translational work on that to see if you can identify some prognostic factors. This is obviously a very good technique. The morbidity may have certain elements, but in general, it seems sufficient, at least to get rid of the tumor. So here you see a very distinguished surgeon who is about to do such a radical approach. And the surgeon, he looks very competent, but then comes a small angel, and the angel tells the surgeons, why do you not try with radiotherapy? And this is what we are going to address. Now, primary radiotherapy of head and neck is not just RT, as you see it here. It is a very complex treatment, and it involves a lot of issues related to the interaction with chemotherapy, with surgery, different fractionation schedules based on a number of biological factors and other issues. So it's a very complex matter, and I'm going to address a few of those. Now, if you will give primary radiotherapy to a patient with head and neck cancer, the recommended treatment may be the following, especially if you or the patient have been surfing the internet. You will suggest that the patient participate in a randomized trial which randomizes to plus minus an EGF receptor inhibitor. You will suggest you deliver the treatment with intensity modulated radiotherapy, so-called IMRT, and where the basic treatment consists of concomitant chemoradiotherapy given in a hyperfractionated, accelerated schedule, and together with a hypoxic modification. And this is because that this is a radiation modifier under exploration. This gives you a better focus and may reduce the morbidity. This secures some radiation sensitization. This allows you to give a higher dose. This avoids repopulation, and this avoids hypoxic radioresistance. So let us take a look at some of these elements. All this, by the way, is evidence-based, and that's nice to know if you have to tell it to someone. So the EGF receptor inhibitor. Well, the chairman has, in fact, done a lot of work of that in his younger days and still do. And this is, of course, based on the concept of blocking the EGF receptor inhibitor, and there is some preclinical data which shows that interaction with radiotherapy and, in this case, cetuximab, in fact, strongly allows you to achieve a benefit and reduce tumor growth. So all this has been evaluated in a very highly exposed clinical trials, which have been randomized, and we all have around our neck some of these things which is a part of that trial or the consequences of it. The trial actually randomized between radiotherapy and radiotherapy together with cetuximab and was published in the New England Journal of Medicine a few years ago. It's what's normally called as the Bonner study. And it showed a significant benefit in both local control and overall survival if you add cetuximab to radiotherapy of these patients. And this was a great news for the FDA, who said that in 45 years you have not seen anything similar. This is the first drug approved for head and neck cancer that has shown survival benefit in this population. That's why you have the hype about the drug, and that's why we all have this around our neck. Now, is this a light thing to have, or is it a heavy burden about the neck? This is the question. Now, it is not a treatment without problems, but it is easily tolerated. It does not compromise the radiation morbidity, but of course it has a morbidity of its own, mainly linked with the skin toxicity. But let's have a word about what all this is about. Now, the so-called Bonner trial has indeed revolutionized the treatment, at least according to the advertisement. It is a relatively small randomized trial. It includes a lot of institutions, and it has used a variety of radiation therapy schedules. The outcome gives an overall survival benefit, but there are large variations between the subgroups, which are not so much mentioned. And the hype of the trial resulted in this FDA approval by a single study. It may represent a major achievement, but in my point of view, it must be confirmed. We need to do that, especially because the treatment may cause more morbidity than we originally claimed, and because the benefit in some subgroups, patients with low performance and high age, may also be limited. So it is an interesting topic, but it is not a closed and confirmed issue. Now, the intensity modulated radiotherapy is the concept we just heard about. It's a concept that you, thanks to computer power and a lot of different mechanics, you can in fact give a number of small portals to the treatment, allow you to confirm your tumor, and allow you also to avoid critical normal tissue, and especially the latter is the issue. And in the head and neck is the avoidance of, for instance, salivary glands, and a very important point. And that has been demonstrated in a few small randomized trials, and we in fact saw one of them just before, demonstrating that you can protect your salivary function if you use IMRT. But there are no data showing that IMRT in fact is beautiful for the tumor. The few trials has been done to show it's beautiful for the morbidity. So let's take a look at the IMRT. The benefit is that you can better focus on the tumor. You might give a higher dose, and you can avoid the critical normal tissue like the salivary gland and the swallowing function. The problem is that you might have an increased risk of radiation-induced cancers because you deliver a lot of low-dose radiation to a large part of the body, and we do not really know what that really means. But it is, of course, a little bit matter of concern because you might enhance your risk of secondary cancer. And then you have always the problem that if you hit something very precisely, you also have the probability of hitting very precisely wrong. And if you give your treatment 30 or 35 times, you have 30 or 35 times of hitting wrong. And this is, of course, of some concern, and we do not know what the consequences of that is, but we should be aware of that. Well, we have not really challenged this potential benefit except for the few trials I showed you. It is intuitively a better treatment, but we do not have strong records of the past performance. We just add it into an unknown field. And it suffers from the problems which all new technologies does, and also surgical technologies, that you're not required to show that it actually is of benefit. You're just required to show it is safe. So if you can plug it into the wall and you can turn the electricity on and you don't get a shock, it's basically okay. And I think we sometimes should ask ourselves if we need more and stronger requirements for both surgical and radiotherapeutic techniques and certain diagnostic techniques before we bring them aboard. But this is a complex thing. The concomitant chemoradiotherapy. Yes, is there a rationale for that? Well, in the 70s and 80s, there was a lot of preclinical studies, and it also embarked on some clinical trials. And the literature has a very clear message saying that we have no clinical gains, and it has demonstrated no benefit, and there is no convincing data, etc., etc. There is basically very difficult to find a strong rationale for using concomitant chemoradiotherapy. But yet some people went on and did it anyway. And we have seen this trial from the ECOG and SWOG showed a benefit of concomitant cisplatin compared to radiotherapy alone, and the same for the European GORTEC group. So obviously it is of benefit. All of these trials also have an enhanced morbidity when it comes to it. But when all the data which has been produced by these chemotherapy and combined radiotherapy trials was put into a meta-analysis, it shows that for the concomitant chemoradiotherapy, irrespective of the quality of the radiotherapy schedule, and it is not always the best, there was a significant risk reduction in the order of 19%. Whereas if you used induction chemotherapy, it was much smaller. So the benefit seems to be in the concomitant chemoradiotherapy. Now, but this is not a treatment which is good for all. And there is just a paper on the way from the RTOG group which shows that the late morbidity is very substantial. About almost half of the patients have severe late morbidity and have problems with the compliance. And also the MAC group has demonstrated that in general for head and neck cancer in trials, and especially for the chemotherapy combined studies, when you increase in age, your benefit becomes smaller and smaller. So it is a heterogeneous outcome, and the compliance is poor. And if you look at all the morbidity of different radiation schedules compared to different chemoradiotherapy schedules, as it has been published and studied by Trotti and Søren Benson, then you can see that there is a substantial enhancement of the morbidity when you combine it with radiotherapy with chemotherapy, up to a factor of 5 or typically 2 to 5 times more, both of the acute and the severe morbidity. So this is not a free lunch. So if you take a word about the concomitant chemoradiotherapy, the meta-analysis has shown an overall benefit in survival, but there's no data on compliance or morbidity or patient heterogeneity in various subgroups. The reality is that the most frequently used and the so-called FDA-approved schedule, which is the 3 cycles of 100 milligram per meter square, has a substantial morbidity and has a poor compliance, and only a fraction of the patients get the full treatment, and radiotherapy is often interrupted. Therefore, has other schedules been sneaking in? They have better compliance. For instance, the schedule with weekly application of 30 or 40 milligram per meter square, which are known from the uterine cervix scenario. But this has not been properly approved or compared with the FDA schedule, so this is not the real schedule. It is not acceptable in our community, I think, that the recommended treatment has such a poor compliance and that only a limited group of patients can tolerate and comply to the treatment. We need something better. And in fact, I think we need, as a community, to go in and embark on a large randomized trial or several trials where the relevant patient populations, in which we compare the efficacy and the compliance of different concurrent chemoradiotherapy schedules, and where we challenge the 100 milligram per meter square 3-cycle schedules, and to see whether we can do something better with milder treatment approaches. We need to do that, and we need to do it in a scenario where we are allowed to give optimal radiotherapy and in forms of fractionation, and etc. But who is going around to initiate such a study, who will support it, who will participate is indeed the questions, and we all have our prejudices about this. But I had to say that the Achilles heel in head and neck cancer treatment, to me, is the so-called standard chemoradiotherapy schedule. It has no rationale. It may not help all. The standard of care schedule cannot be tolerated. The side effects are too large. It interferes unfavorably with compliance to some other treatments, but otherwise there's no problems. But we need to do something about it. Now, what about the fractionation? Well, fractionation research has been a major element in radiotherapy, and especially of the head and neck cancer. And the issues has been to put in more power, that means to increase the dose, or to put in more speed, that means to accelerate the treatment time. Now, the more power is due to the fact that there is a steep dose response curve for head and neck cancer. So when you increase the dose, your likelihood of getting better tumor control is strongly increased as well. And in head and neck cancer, it is so steep that a dose increment in the order of 10% may increase the tumor control with a 10-15%, depending on where you are on the curve. But you just need a little bit to actually get something out of it. One way to do that is to use hyperfractionation. The concept of hyperfractionation is that if you give smaller fractions, a smaller dose per fraction, but to an overall higher total dose, you can achieve that without enhancing the risk of late morbidity, but bring in a higher total tumor dose. And this has been known for a long time. It has also been tested in various clinical trials. The first trial was a study between conventional fractionation and here hyperfractionation by the EURTC, and this showed you have improved local renal control without any difference in the late effects. And in fact, the meta-analysis on fractionation, which was published a couple of years ago, clearly indicate the hyperfractionation result in a very substantial risk reduction, the largest risk reduction we actually have seen when we have done the meta-analysis. And it also influenced the deaths of cancer in about the same magnitude. So there's no doubt that hyperfractionation represents the strongest biological means to improve tumor control with radiotherapy. Increasing the tumor dose is most likely method to increase control in both the T and in the N position. And that can be achieved without enhancing the late morbidity. It is probably homogeneous. That means it might benefit all patients. And the effect is translated into improved survival. So it is, with Tina Turner, simply the best. Unfortunately, it demands more resources. The accelerated schedule comes out for the point and observations that when you increase the overall treatment time, you need a higher dose to yield the same outcome. And the reason for that is that you have clonogenic tumor cell stems which probably are stimulated to faster growth when you start to give your treatment. So during treatment, you stimulate a growth of the cells, and therefore you have more cells to kill if you protract your treatment. And in the opposite, of course, if you can shrink the treatment time, you may have less cell and you may control more tumors. And this is the concept of the accelerated fractionation. In one way or another, you have to reduce the number of treatments. And we have done that by comparing 5 fractions per week with 6 fractions per week, just give an extra fraction in the afternoon or on the Saturday. And that was done by the so-called DAHANKA 6 and 7 trial. And the outcome showed that you have a significant benefit of reducing the overall treatment time, both in local control and in disease-specific survival. The price is you have some enhancement of the acute radiation reactions expressed here by the mucositis, but no influence of the late if you do not compromise or press the time down too much. The effect of acceleration is especially seen in the T side, whereas you have less benefit in the N side. This was seen in that trial, and that has been seen in other trials as well. So it seems especially to be a factor related to the T side. So it leaves the nodal disease a problem. But it has significantly benefit on the probability of securing larynx preservation, so you enhance your organ conservation if you use such a schedule. And if you look in the meta-analysis, you find again a substantial reduction in the risk in terms of local renal control, but less influence on the cancer death, probably due to the lack of influence on the lymph node disease. So moderate acceleration yields a substantial overall improvement in local renal control. There's some increased acute morbidity, but no enhanced late morbidity if you limit it to a reasonably reduction in the order of 1 week. The effect may be heterogeneous, and not all may need acceleration. It has a limited effect on the nodal disease, and therefore a smaller survival benefit. On the other hand, it is a schedule you can export, and most of this has been generated in the more developing world, but that specific schedule was also tested as a part of the IAEA, the Atomic Energy Commission, which used to do trials in the developing part of the world. And this study here was done especially in Pakistan and India, and it shows exactly the same outcome in a more heavy population of patients, that you can achieve the same gain. So it is a global result. Now, can we predict the tumors which especially may benefit from accelerated fractionation? We do not know, but there are some indications that patients who have moderate and well-differentiated tumors are doing better. They are the ones who have more repopulation. and if they express EGF receptors, they may also have a benefit of that. We need more explorations, but there are indications in that direction. So if we have to conclude on the novel fractionation schedules, we can say that large trials give the evidence that radiotherapy in head and neck cancer can be significantly improved by using altered fractionation schedule, such as hyperfractionation and/or moderate acceleration, but we shall not reduce the total dose. In the same way as we have a benefit by hyperfractionation by increasing the dose, we might lose if we decrease the dose. So don't sell out, don't sell time or buy time with decreasing dose. Keep the dose and try to get it as high as possible. We can do that with some enhanced acute morbidity, but avoid late enhancement. Such altered fractionation schedules, in my point of view, must be considered the standard fractionation for head and neck cancer. Conventional fractionation is out. I think we should be aware of that, and when we go in and compare, and it was discussed yesterday as well, compare other schedules and combine schedules, and we use conventional fractionation, we are actually using an inferior radiotherapy modality. The last issue is the hypoxic modification. We know that hypoxic cells are radioresistant. We know that head and neck cancer, in fact, are very frequently hypoxic when we measure it. And we also know that the outcome is so that if you have hypoxic cells, you have a much poorer outcome. So the issue is, can we modify that? And that has been done in different fashions, and there are also some reports at this meeting here. One of the most explored things has in fact been used to the so-called hypoxic radiosensitizers, which mainly have been nitroimidazoles. And among the studies has been a study which we had done with a drug called nimorozole, demonstrating that nimorozole added to conventional radiotherapy, in fact, enhance the outcome and secure you a better local retinal control. And that also influenced the disease-specific survival. And there have been many small such studies, and not all have reached the conclusion by itself, but if you bring them into a meta-analysis again, you will see that there is an overall risk reduction by using hypoxic modification in the order of 13%, and also some influence on the disease-related survival. So using hypoxic modification may be a benefit. It is a free activity. It doesn't cost you enhanced morbidity. It is supported by the meta-analysis. It is obviously heterogeneous, and not all patients may need the hypoxic modification, and we had to do some prediction. On the other hand, if we do not apply it, then nobody gets the benefit. And the question is, of course, can we find the patients which are sensitive? And just to illustrate that that might be the case, for the same DAHANCA 5 study, in fact, it has been described and also been discussed here at the meeting that there are certain markers. One can be osteopontin in the plasma. This is a part of the HIF cascade. And if you look in and see which patient might have benefit, it seems the patients who have the high expression of the osteopontin indeed are the ones. And the message is just that you might have the option for getting markers which can be predictive in identifying the patients who may benefit. The benefit of hypoxic modification, as I said, is free, and it can be obtained without any increased radiation-related morbidity, and the treatment is fairly inexpensive. There is abundant information from the clinical trials, and the meta-analyses have indicated that especially in the head and neck, you have a benefit. So this use must be considered to be an obvious evidence-based possibility for improving the radiotherapy. We have known that for 50 years, and we do not use it. And this is an interesting way to see how we do not adapt the simple stone, or pick up the simple stones we can do in order to make our path and road more pleasant and smooth. But we always embark on something else. And this reminds me just to say that radiotherapy is not just RT, but it's a complex treatment where small changes can result in major variations. And I have sneaked in to show you a few studies here, and this is just the one I showed before, demonstrating the benefit of hypoxic modification. And if you take that trial and take the best arm in that study and put it into a new study and then give that with accelerated fractionation, you can see how you can bring your best arm into a control arm, and then you can improve further by modifying proliferation. So this illustrates how two small means here can improve the outcome of radiotherapy in the advanced head and neck cancers from the standard conventional to an improved one based on a treatment which is the same total dose, the same number of fractions. You just give a pill and reduce the treatment time with 1 week. So this is an illustration just of the benefit of hypoxic modification and of acceleration. Now, if you then add some of your predictive knowledge in terms of the osteopontin I showed about hypoxia and some of the high ADF receptor expression, you can see that the difference here becomes quite substantial in the an odds ratio about 3.89. And if you add further to that knowledge about the HPV status, as I will come back to, you in fact will see that by giving such a treatment, you can split up your variation in the cohort with an odds ratio of 10. So you can indeed identify patients at various levels of risk which might be useful in your way to apply your radiotherapy in an optimal thing. And this is not by fancy radiotherapy, this is by very simple means. This, of course, needs to be explored, but it illustrates the power you still have left. So applying radiobiological principles like hypoxic modification and acceleration, I have chosen these two because all the other fancy things cost more resources. And I remember that I told you that 3/4 of the patients are in the developing world. So we cannot develop our techniques on something which are very fancy and demand a lot of issues. We must use things which are globally applicable. And this here does not demand additional resources. So hypoxic modification, these are relevant and they may significantly improve tumor outcome. So the message is that there's still much power to be gained from simple radiobiological maneuvers. And the correlation, of course, is that the lack of doing such things may bring us into deep trouble. So far, not a word about, and not very many about, nasopharyngeal carcinoma. We heard a beautiful lecture before, or radiotherapy as an adjuvant to surgery, or about the salvage treatment. But basically, we can say that what is good for radiotherapy alone is also good for radiotherapy with nasopharyngeal carcinomas, and it is also good as a postoperative radiotherapy. And when it comes to the salvage surgery, it might be useful in small larynx tumors and it may be useful in some neck. But in general, I think that it is less successful when it comes to secure long-term tumor control. It was very impressive what we heard before. But I think we should not rely on salvage. And it has a much better word than the truth is. There are still many unsettled issues in head and neck radiotherapy, both related to which patients to treat, which treatment, and how we should apply it. And in order to improve this is the way forward to do large intergroup trials to address the issues. We need to collaborate. It is the best way to bring our knowledge forward. But here we have a problem with human nature, because we always have a tendency to embark on new ideas and projects before we have concluded and come to terms with those of the past. It may be okay if you want to advance the academic science, etc., but it may not be optimal if we will improve cancer treatment. We cannot afford to have too many missed opportunities. And if you see what we have left behind us in our eagerness to move forward, we have a tremendous resource of good evidence for how we can improve day-to-day treatment, which we ignore instead of getting into something new, tricky things, which can be quite difficult. So therefore, how do we really progress? How do we reach the summit? And we have to take the lesson from the explorers. First of all, we have to go up and we have to stand where we come to. We have to move to the base camp. And once you reach the base camp, you don't run down to sea level again and start from a new direction. You have to recognize your achievements. And we have to know the tools which will bring us to the top. And if you want to go to the top, it has become clear that at least the following things are needed to reach the top successfully. It must be a teamwork. Otherwise, it will not go. You have to go for it. You have to secure the highest dose. The climb must be fast. It must be accelerated. and you cannot do it without oxygen. And then, of course, you should not expect to be rescued if you fail. Now, I have shown you that there are many factors related to radiotherapy when you have to do things. There are also other biological factors. And in fact, it is so that the key etiological factors causing head and neck cancer does also strongly influence the outcome to radiotherapy. And one key factor is smoking. And it is so that, in fact, if you look around here and you see the outcome of the patients, I showed you before the deaths related to head and neck cancer. In the same cohort of patients, you can see the total deaths. And there is a significant excess death in patients which are cured for head and neck cancer. And that excess death is due to comorbidity and new primary cancer limited, which make it more and more difficult to achieve the benefit of new therapies. And especially the problem with the elderly patients is very much related to excess comorbidity. And this here is very much also related to smoking. And I like this picture because I took a photograph of that. And these are produced by head and neck oncologists at a coffee break at an international meeting. So you are all very good. Thank you for your contribution to this picture. Now, what you can see here is that smoking has a significant outcome on radiotherapy, and smoking during radiotherapy indeed results in a poor outcome, probably because you make the tumors, in fact, slightly more hypoxic, and also in terms of overall survival, because you have this excess risk of dying for other smoke-related diseases. So one message is very clear. If smoking is an issue and you give radiotherapy, the patient shall not smoke. They must cease their smoking. This should be obvious, but if it's not obvious, it has been said now. Otherwise, you compromise the outcome very substantially. The other factor is the HPV, which was also presented here at this meeting. And the good message here is that we see this changing pattern and the rise of HPV-related tumors. But tumors which are HPV positive are doing much, much better in terms of radiotherapy. And in fact, the outcome after radiotherapy in HPV-related tumors, or in this case P16-related tumors, has shown out it is a very strong prognostic factor for radiotherapy in head and neck cancer. So the good news here is that these patients, in fact, are very good candidates for radiotherapy, also if you have a large nodal disease component. Yes, gentlemen, you can turn around now. So do that. And then you must remember, whatever you do, it must be in a multidisciplinary teamwork. And if you should be successful, it must include radiotherapy. Thank you very much.
I was at an IFNOS meeting a couple of years back when I heard Dr. Overgaard speak, and I said, I know who I want to be my keynote speaker for this particular topic. So thank you very much on behalf of the Head and Neck Society.